You're welcome, sir.
Okay, let's start.
Okay.
This common cold disturbing me. Just drinking water. Okay, we were on class one A done. The important thing about 1B done. Okay, now come to class 1C. Anything special about 1C? At what time you use 1C? What time? When any other drug is not working to control your rhythm. Okay? Not directly go for 1C. Why you not prefer 1C? Because 1C is very strong sodium blocker. It can cause cardiac arrest. Okay? It can cause cardiac arrest. Okay, listen here carefully. If the patient have a heart attack, listen here carefully. If the patient have a heart attack, can you use class 1C? Never go for 1C. What's the important contraindication? If heart have any structural problem, okay? Heart have any valve disease, heart have, like, for example, myocarditis there, post-MI, ischemic heart disease. So if the patient having any structural issue with the heart, never use 1C. Keep in mind, okay? If any structural issue, especially post-MI, listen here very carefully. 1B is it's a gold standard drug after MI. Just now explain, okay? 1B is a gold standard for, like, if a patient have MI, I give 1B. How about the 1C post MI? Can you go for 1C? Never go for 1C. Okay? Any structural problem, especially MI, never use 1C. Contraindicated in if heart having any structural issue. Clear? Why you not using this? If heart is already damaged, if heart electricity, all the thing, conductive system already down, is not working properly, if the patient have healthy heart and have arrhythmia, you can use 1C, very no problem. Okay, if the heart have any structural issue, never go for 1C, can cause cardiac arrest. It's a very important thing about 1C. The 1C very dangerous drug. We not frequently use this drug. Okay, 1C. So 1C can cause cardiac arrest, especially why it's not most frequently used, because the heart have disease, heart have valve disease, heart have myocardial disease, yeah, have myocardium disease, heart have like ischemic heart disease. The heart have already structural problem there. That's why I'm not using 1C. This is the reason why you're not using 1C frequently, because heart have structural problem. For structural problem. If patient just have arrhythmia, healthy heart, no disease, just heart rate very high, then you can use 1C. If any pathology already inside the heart, then avoid 1C. Understand the important concept about 1C? It's very dangerous, can cause, it's very strong sodium blocker. It can block all sodium channels. It can block all sodium channel. Understand? It can block all sodium channels. So must be careful about propafenone and flecainide. Propafenone and flecainide. Okay, now come to beta blockers. Class 2. Beta blocker class 2 we also can use for any category of arrhythmia. Beta blocker, you only take care about a respiratory system. This you know already. Beta blocker, you must take care about asthma. If the patient have asthma, you must take care of if the patient have COPD. Okay, it's the main contraindication. Other is no main contraindication for beta blockers. Okay. How about the class 3? Class 3 amiodarone is having lot of side effects. Having lot of side effects. Okay. How about the class 4? Calcium channel blocker, cardioselective. Yesterday we done about the class 4. Calcium channel blocker we also use in MI patient. Yeah. So calcium channel blocker, diltiazem and verapamil. If you remember the side effects of verapamil, diltiazem, side effect, gingival hyperplasia, prolactin increase, okay, gingival hyperplasia, and prolactin increase is related to calcium channel blocker. Okay. Okay, now come back again to class one. How class one? These key points done about this class. Class one, Punidine synchronism, diethylpyramide heart failure, procainamide SLE. Okay. What is synchronism? Headache, tinnitus, GI upset. How about the class 1B? Class 1B we use very effectively in MI patients, post MI patients. Lidocaine in hospital. When patient come back to home and still MI patient, okay, after management in hospital, we use lidocaine. At home, we give mexiletine and procainide. Clear? Okay, class 1C. Class 1C, very strong, very strong, very strong sodium blocker. So must be careful if heart already have any structural problem, especially MI. Contraindicated in MI. Contraindicated in MI patient. Understand? Contraindicated in MI patient. That's your class 1C and class 1B and class 3. Here's the class 2. That's your class B. Class B beta blocker. Class B beta blocker and class 3 potassium blocker, amiodarone and sotalol. Amiodarone and sotalol very effective drug to treat any type of arrhythmia, but the problem side effects. Okay, and class 4 is your group class 4 is your calcium channel blocker. Now again come back to class 1. How the class 1 is working? Class 1 they have been three types. One is 1B, 1. The sodium channel, if you remember the physiological aspect of sodium channel. So what are the state of sodium channel? The sodium channel having three stages. Number one, sodium channel may be inactive. Number two, sodium channel may be active stage. Number three, sodium channel may be resting. Inactive sodium gate. Inactive sodium gate. Inactive sodium gate like if the sodium gate having two doors here. The sodium channel, one gate active and one gate is your inactive. Inactive sodium gate is your active. So this one is active sodium gate. This one is your inactive gate. Understand? So active and inactive. What mean the resting? We have two door here. This is a way. This is a door. This is an opening. Okay. One is active and one is inactive gate. If active gate is open, it means the sodium gate is active. The active mean the muscle under process of depolarization. Okay. When the muscle depolarized, muscle depolarized is your now sodium gate undergo rest. But the stage in rest, everything closed like this. Active gate also closed, then active gate also closed. Okay. That's your resting phase. This one, class 1, if the tissue is depolarized, or if the tissue is depolarizing, if inactive gate is open, this tissue is depolarized. Now the patient, now the muscle cells have been undergo resting stage. The class 1A acting on inactive gate. 1A, there's a 1B. 1B, when the muscle is totally depolarized. Muscle totally depolarized. And 1A acting when muscle under process of depolarization. Okay, muscle under process of depolarization. At once, this 1C act on this 1C when act on the channel, which stage? When the channel is resting stage. Channel in resting stage. Okay, so 1A, A, how you can keep in mind. A for active. 1A act on active gate. 1A act on when active gate is at open. Okay, that's your active gate side. 1B act on inactive gate. One C acts on number one thing, resting gate, also acts on inactive gate, also acts on active gate. All sodium gate not depend upon the state, okay? It can block everything. It can block everything. All sodium gate condition are blocked. The sodium gate responsible for depolarization. The sodium gate undergo rest. Sodium gate already depolarize the tissue. Every type of sodium gate is blocked by one. See, that's why it's very strong. This reason is very strong. Okay, when the muscle is depolarized, muscle is depolarized at that time. Active gate, this inactive gate is closed. The sodium gate state is inactive. The one B act on inactive gate. One B act on inactive. The inactive gate is open. That open gate is closed by one B. Okay. So if the tissue is already depolarized. If the normal healthy tissue under process of depolarization, that time active gate will open and one B act on depolarizing tissue. Again, summarize this sentence. One A act on which gate? Acting sodium gate. Which gate? Active sodium gate. This state at what time? When the tissue under process of depolarization. The tissue was depolarizing. Okay. Inactive gate, when tissue already depolarized. Inactive gate, this drug acts on inactive gate. If tissue already depolarized, if tissue already depolarized, okay. And third stage, what the third phase? The third phase of sodium gate is the resting gate, having three phases of sodium gate. Okay, three phases. If both are closed, listen here carefully. We have two doors here. One is active and another one inactive. If these both are closed, this phase known as resting. Understand? If this active open, if the active, this will the upper one is active. This one open. It's your active gate. Clear? Now, what's the inactive? In inactive, this active gate will open and inactive gate is closed here. Inactive gate here. This is your inactive gate. So in inactive gate, what happens? This active gate like close like this, but the downside, this gate still open. This gate still open. The sodium still not enter this. So this phase of gate showing what? Tissue already depolarized. Okay, if the both gate active also like this, inactive also like what is this stage? This stage is resting stage. This stage is resting stage. This means now the tissue under resting stage. Understand? Active gate means if active gate is working, it means tissue under process of depolarization. Sodium and both gate active and inactive are open. The sodium enter. Sodium can enter. Okay, easily can enter. Now, when the inactive this inactive phase, these are the phases. Okay, these are phases of sodium gate. Phases. Understand? These are phases. Phases are state of sodium gate. Active or inactive or resting. There are three phases of sodium channel during depolarization. Understand? So first one, active. Inactive means sodium enter. Active means sodium enter. And what happened in inactive is the stage, this stage like inactive gate. In inactive gate, can this sodium enter? This is out one door, okay? Outer door. The inner door is still open, but the outer door is closed. Still sodium not enter. If the gate like this, it means tissue already depolarized, no need more sodium. Understand? So the 1B acts on which tissue? The tissue already depolarized. 1A acts on which tissue? Tissue under process of depolarization. 1C, now come to 1. We have three stages of gate. 1C, three stages of gate. Number 1, this gate open, this gate open. This is your active gate, okay? Number 2, this gate closed and this gate open. I just give the number. Gate number 1, gate number 2. Gate number 1, gate number 2. Gate number 1, gate number 2. Now more clear, okay? This gate is active gate, this gate is inactive gate, and this gate is your resting gate. Understand? Now let me know during which sodium can enter. Sodium can enter which gate? Which one open? Here sodium can go inside the cell, okay?
Mm.
Can sodium enter through inactive? No. Can sodium enter to resting? No. So what's active gate show? Tissue under process of it means depolarizing. Okay. What the state inactive showing? Tissue already depolarized. Understand? What's resting? Resting is resting. Clear? Class 1A act on active. Class 1B act on inactive. Class 1C act on where? Also block this, also block this, also block this. Class 1C act on all sodium channel. Understand? If any gate open, that gate also locked. If any gate already locked, that gate further locked by 1C. If any gate in inactive state just now depolarized the tissue, that gate next time not open. Okay, all gates are locked by 1C. That's why 1C is dangerous. Clear? Okay, now come back to 1B. So why we use this drug in MI patient? In MI patient, if you have physiology idea, current of injury, this your normal cell inside, negative outside, positive. Okay. So if you damage this cell, myocardial infarction, myocyte, what happens? Inside charge come out. So in the area, if the MI there, that area become what? Inside charge come out. So what is this charge? Negative. Understand? This charge is negative charge now outside. It's mean the injured part is clear or not? Injured part depolarized or partial depolarized. This is the basic physiology idea. The damaged myocardium produce depolarizing current. Okay, partially or permanently depolarized. So that depolarized area. So can you tell me if the tissue already depolarized, which what is the state of the sodium gate, active, inactive, or resting? If tissue already depolarized, what is the state of sodium gate? Sodium gate have three states. Number one, active gate. Number two, inactive gate. Number three, resting gate. Okay, active, inactive. If the tissue already depolarized in injured area, in myocardium, myocardial infarction, tissue myocardium damage, that damaged myocardium produce negative charge. It means that area is depolarized. So depolarized area, in that area, the sodium channel, which state? In depolarized area, sodium channel which state? I just now explained a lot. If the tissue already depolarized, the sodium gate in which stage? Sodium gate inactive. Which drug acts on inactive? Which drug acts on inactive? Why I am not giving 1A? Why I am not giving 1A? 1A acts on active gate. In damaged myocardium, the current is produced by injured area. All the sodium gates are inactive state. So mostly the sodium gate in damaged myocardium in which state? Inactive state. That damaged myocardium produce extra current and causing arrhythmia. So that's why this is the big reason I'm explaining here. This is the big reason the gold standard drug after MI for arrhythmia is 1B. Understand? Class 1B is a gold standard after MI because that depolarized part, sodium channel state inactive. Inactive state 1B. Which 1B? Lidocaine IV. Maxilitine when you send the patient to home. Okay. For oral therapy, maxilitine and propanide. Lidocaine for IV use in hospital setting. Understand? So this is the reason why you use in the post-MI patient. So why class 1C is very strong, you can see here. This one is with moderate action, block the depolarizing tissue. And this is a weak action. You can see the weak action. Tissue already depolarized and act on that tissue. Understand? That's why it's a weak. Tissue already depolarized and block that sodium channel. That's why it's a weak. And why one C is very strong? It don't see with the sodium state. It just see, oh, it's a sodium gate, active, resting, or inactive. I don't care. One C don't care about the state. One C don't care about the state. Understand? One C don't care. It just blocks sodium gate. Sodium gate inactive. Sodium gate active. Or sodium gate resting state. It just see the sodium gate, not see the state of the sodium. Understand? So class one, in your book may be written one terminology, state dependence. What is the mean? This is the only property of class one, state dependence. Only property of class one. What's mean state dependence? It means the sodium gate having three stages, yeah? Three states there. Active, inactive, resting. So there are the drug here 1A and 1B and 1C. Okay, 1A and 1B and 1C. How they work on the sodium channel? They first see what is the state of the sodium channel. 1B only go for inactive. 1A only go for active. Understand? This is the state dependence property. State dependence property. No other antiarrhythmic have this property. They just go block calcium, they just go block beta receptors, just go block potassium channel. They don't see the state, okay? The state dependency is the property of class 1. Another very important concept about 1, okay? The state dependency. They see what is the state of the sodium channel. Okay? Another idea about the class 1, a class 1 drug. Class 1 drug also act like antimuscarinic. Oh my God. Class 1 also acts like antimuscarinic. Why you worry about this? They also act like antimuscarinic. What do you think about your side effect? Oh, atropine like side effect, yeah? Atropine like side effect, dry eye, dry mouth, dry skin, and these hyperthermia, all these side effects. This is not the problem for this. The big problem here. If these drugs also act like anti-muscarinic, okay, we having how many group here? 1A, 1B, and 1C. This one, class 1A, very strongly block M3, block M3, also block M1, M2, M2. If you remember on node, understand? M2, yeah? M2 on node and M1 on stomach. Okay, class 1, here I put the three class here. Class 1B block like this. Okay, class 1C block. Which one more stronger anti-muscarinic? One. Try to understand here, okay? Which one is very weaker anti-muscarinic? One, two. So which one can produce atropine-like side effect more? Atropine-like side effect. Atropine-like side effect. Dry eye, dry mouth, constipation, urinary retention. Okay, dry eye, dry mouth, loss of sweating, and hypothermia, and these are the side effects. Okay, which side effect is very important here? I'm not telling you. What is the side effect of atropine related to heart? If you remember, what is the side effect of atropine related to heart? Let me know. Side effect of atropine. You remember atropine? What the use for atropine? Used for cardiac arrest. Atropine stimulates the heart. What is the function of M2 receptor? M2 receptor decrease the heart rate. This you know, normal physiology.
Yeah.
Parasympathetic system decrease the heart rate. Now, if I block this receptor, anti-muscarinic, you block this receptor, what happens with the heart rate? What happened with the heart rate? Let me know. What happened?
Grace.
Oh my God. You, on one side you saying that I want to reduce my heart rate. Another problem here is increasing the heart rate. Understand or not?
Yes,
On
sir.
one side you want to decrease the heart rate. Now the problem here, what the problem with the class 1, what the main problem? Not think about that dry eye, dry mouth, the side effects. These side effects, these are common things, okay? If they act like atropine, of course they cause the constipation, they cause you neurotension. So these are not much important for me, okay? The main thing here, I focus on my heart. So if you block M2 receptor on node, if you block M2 receptor on node, what happens with the heart rate? On one side, you're doing to you try to decrease the heart rate. Another side, when you block M2 receptor, you also increase the heart rate. Now, what happens with the heart? You want to treat tachyarrhythmia, you want to treat tachycardia, you give sodium blocker 1A. On one side, sodium blocker 1A try to, of course, decrease the heart rate. But the problem here, on another side, they stimulate the node because anti-muscarinic. So 1A, the problem here, anti-muscarinic, very strong anti-muscarinic. I put a 3 class here, which means very strong anti-muscarinic. So this problem also, one side also increase the heart rate. So what we do here, if you want to use 1A, listen carefully. If you want to use 1A, before using 1A, you must give the digoxin first. Oh, if you want to use for atrial flutter, for atrial fibrillation 1A, you must give digoxin first. What is the action of digoxin? Digoxin act on node and block the node. Okay? Digoxin act on node and block the node. Digoxin has dual action. On one side, digoxin stimulates the myocardium by putting more calcium. On another side, digoxin blocks the nodal activity. Okay? Digoxin blocks the nodal activity. First, you must give digoxin. Digoxin comes from digitalis. Oh, it's a digitalis. Yeah, it's a digital digoxin, the same thing. It's the phenomena known as digitalization of the heart. Digitalization of, what the meaning of this? Digitalization of heart. You, before you use 1A, do what? Digitalization of the heart. It means first use the digoxin before giving 1A. Understand why you want to do this? Because I know this 1A block M2 and again causing heart rate very high. I want to reduce my heart rate, but at the same time M2 block. M2 present where? Node, yeah, SA node and AB node. So again heart rate increase. So before using 1A, must use digital. Before using 1A, must use for any category of the 1A a very effective for SVT. If you want to treat any category of SVT, you want to use 1A. Before using which drug 1A? Before using quinidine, before using disopyramide, before using procainamide. Okay, so before using, I must give first digital or digoxin. Same. Digitalis or digoxin. Why you want to do this? Because I know that quinidine disopyramide also act on muscarinic receptor M2 and block this, or they stimulate the nodal stimulation. Understand? So what the digital is doing here? Digitalis will block the node. Then no more heart rate increase due to this effect. Understand? Then no, this is a very important concept about one. All antiarrhythmic. All antiarrhythmic are very easy, only one class. Class 1 have many things to do. Okay. The class 1A, I must combine with digoxin. I just give you an example. It's the atria. If you know atrial flutter, flutter having part of the wave and heart rate, atria very pumping at a 250 or 200 rate, yeah, and atrial fibrillation 350 rate, or atrial fibrillation. So these are the SVT, okay? These all are SVT. So what happened? Atria rate is very high. What you want to use? Class 1A. If you use class 1A, here is your AV node, here is your SA node, okay? So receptor present here, M2. So if you use class 1A, I already explained, it's a strong anti-muscarinic, also block this. If also block this, what happens? This current from atria very rapidly comes down. And this person before have atrial fibrillation, now having ventricle fibrillation. So atrial fibrillation changed to ventricle fibrillation, you kill the patient. No more, but now chance for life is very less. Most common arrhythmia asymptomatic. If I have atrial fibrillation, I'm walking here and there, I have no problem. One patient come to you just saying, "Hey doc, I have palpitation. I just feel my heart is beating. My heart is running so fast." Oh, that patient have atrial fibrillation, yeah. That patient may have atrial flutter. Hey, you go and eat 1A. At night, the patient eat 1A. You not give the digoxin with that 1A. That patient died due to ventricular fibrillation. What you done with patient? You block. You here you not block the node. You stimulate the node. Where atrial fibrillation change to ventricular fibrillation. It's a life-threatening arrhythmia. Okay, it's a life-threatening arrhythmia. You can't control. You just can see just before death. This ventricular fibrillation. That patient had the simple atrial fibrillation or atrial flutter, you change to ventricular fibrillation, ventricular flutter. The ventricular fibrillation or ventricular tachycardia. Understand? So this is important. You must do the digoxin before giving 1A. Understand? You must use the digoxin before using 1A. You must solve this question. Why need the digoxin before 1A? Why we need the digoxin before 1A? What will be your answer? Strong, nodal stimulation done by 1A by blocking. Understand or not? Why
Yes, sir.
1B and 1C? Why 1B and 1C? You not use with that because they are weak antimuscarinic. They're not causing increased heart rate by blocking M2, okay? Because they are weak antimuscarinic. Class 1A, very strong antimuscarinic, so it also on one side try to decrease heart rate. So if you give medication to decrease the heart rate, and that person saying, hey dog, you give what medication? After eating this, my heart is now beating more faster than before. What you have done to me? Because you're not used digestion before warning. Understand? Must use. This is very important concept regarding one. Clear about one class? Every aspect hope so you guys done. Yeah?
Yes, sir.
Class one, I explain in detail, too much detail about one. Okay? The just the important class left is just read the beta blocker, calcium blocker, very easy. Just I will explain this amiodarone tomorrow, inshallah, their side effects and everything about the amiodarone. Understand? Try to
Okay,
revise
sir.
this class one.
Yeah.
It's enough for this class. Hope so. I will try to make this and it make more easy for you guys now. Yeah?
Yes, sir.
Now it's more easy. You can memorize it. Okay, see you inshallah tomorrow. Assalamu alaikum.
Okay, sir. Walaikum salam.
Allah
Thank
Hafiz.
you, sir.
Thank you, sir.
Welcome.
Allah Hafiz.
Welcome.
Allah Hafiz.
Allah Hafiz.
Waalaikumsalam.